Well, hey everybody, it's Sandy and welcome back to my channel dedicated to helping you advocate for your own health, one topic at a time. Guys, today I wanted to do a video that sort of think about it as a public service announcement. This has to do with lipids, cholesterol, your lipid profile that probably you have drawn about once a year, regardless of whether you're on a statin. I think over 40, most primary doctors, internists have patients get their blood drawn about once a year and look at the lipid profile and make sure everything's okay. So there's a problem with that now, and it's become glaringly obvious just how big a problem it is, because I have recently taken some classes from a lipidologist, and I'm going to put in the description box when I finish this video probably a couple of podcasts or a couple of YouTube videos with a lipidologist interviewed by, I don't know, maybe I'll do one. I think Dr. Peter Attia has one, although I think that one's really long. I'll take a look and see what I can paste down there. But here's the issue. Lipidology is a very new and budding field. There is so much to it that is just not even on the radar screen yet for primary doctors, namely internists and frankly even cardiologists, that the risk assessment you get from a lipidologist is entirely different than the risk assessment you get from a primary doctor or even, like I said, a cardiologist. There's a couple reasons for that. I'll go into those in just a moment. But the risk assessment is entirely different, and frankly, so is the drug repertoire if you decide in consultation with said doctor or specialist that you want to go ahead and mitigate some risk, some of your cardiac risk. Like, for example, some people take statins, but there are a number of other things available, and there is a lot of this testing that would determine whether even a statin is the best thing for you. It could be that something else that's a little more benign than a statin is actually best for you, depending on your genetics. Turns out that almost all of how we process lipids, and therefore almost all of any kind of lipid abnormality, is genetic. It doesn't mean you're off the hook in terms of lifestyle choices. Doesn't mean you can't impact it. But most of this is how your body deals with fats, whether your body is an oversynthesizer, meaning an overproducer, or an overabsorber of cholesterols is largely genetically determined. And there's all kinds of things that a lipidologist looks at that's, like I said, it's not even on the radar screen yet. So that's the first issue. The second issue is that there is a way that we've been doing a risk assessment and determining whether a patient should be on statins. That's kind of the drug of choice these days for high cholesterol. I'm not saying that's the best thing in all cases, but I'm just going into this to show that the tool is outdated, and it's unfortunately still being used by primary doctors and even cardiologists who do not have lipidology training. So there is something called, I think it's ASCVD, it's a risk calculator, and you can look up cardiac risk calculator. It's a 10-year risk calculator, and you plug in a few different things, including your LDL cholesterol and your blood pressure, a couple other things, and it spits out a percentage, the risk of an event, a cardiac event, within the next 10 years. So, which is why we even focus on cholesterol, because it's supposed to allow us kind of a window into assessing what our cardiovascular risk is. Supposedly, not supposedly, for sure, if you have issues with cholesterol, it can get deposited into blood vessels in the heart. The coronary arteries become narrowed, reduces blood flow to the heart, and ultimately puts you at risk for a heart event like a heart attack or sudden cardiac death. So the problem with using this 10-year risk calculator is, first of all, it's not even using the right things anymore, because LDL is not the only marker. I think the rapidly emerging gold standard for determining risk is actually apolipoprotein B, ApoB, and most doctors are not even ordering that test, and they don't understand it. So, but that's not all. The other issue is, like I said, this calculator is a 10-year risk assessment. So, since we have more information now and we can do 20-year risk assessment or 30 years, do you really want a 10-year risk assessment? In fact, the reason that I'm so well schooled on this is because I was just trying to help somebody else who has kind of a funky lipid profile, and I took this information that I had learned and we went ahead and ordered an ApoB, and we put everything together, and the primary doctor and even the cardiologist said, we don't really treat that, even though you had he got a coronary calcium score, which is a CT without dye, so it's a very simple test. It's a CT of the heart, and they can look at the vessels and see if there's any calcium plaque in there. That's a little bit of a late finding, but that's another story. And this person had a calcium score, but it was low, but I guess a lot of people at 65, he's 65, so they have calcium there. But it really should be 0. We shouldn't have any calcium in our arteries. That's not where it's supposed to live. So both cardiologist and an internist told him this is limited enough that we don't treat it. So we went ahead and took an ApoB, got all these things together, and went to a lipidologist. And whole different story. And now he's in the middle of a workup with a huge panel of Berkeley profile, like I said, which is a combination of several different tests. So that's a whole other story. You would never know that these were all doctors who were all looking at the same case. So, at 65 years old, I don't know if you want to be confined to a 10-year risk calculator. Do you really want to just not mitigate your risk for another 10 years and then see where you are? Maybe you should do things to mitigate the risk for 20 or 30 years. I also don't want anybody that I care about or other people to have heart attacks at a longer date. So I think now we have the ability to assess risk further out, and there's no reason to be confining ourselves with a 10-year risk calculator. It's just not pertinent. So those are the main reasons to go to a lipidologist, and really be careful, even if you've been under good control and you have been treated by your primary doctor, and you have a great primary doctor, and it could be that a lipidologist would agree. I have just learned so much in recent weeks and months about everything that's emerging in this field that I think in the next 10 years this is going to be its own field, and other people aren't really going to be treating this, or other people are going to be taking these classes and continuing education if they're going to be treating it at all, like internists, for example. So where do you find one? Yeah, it might be hard. It might be a drive, or it might mean that you have to do a virtual consultation. There is a lipidology society now that you can look up. I will put that website down below in the description box, and in there you can click on something like find a provider in your area, and it can be arranged by state, or you can type in a zip code and give it an area where you want it to search. But I will tell you to be careful about one thing. Once you look at the providers' names that it spits out, they either have the training or they are actually lipidologists. Now, usually the lipidologists are also cardiologists, but there's a difference in my mind. If I'm going to go to all the trouble of finding somebody who can help me with this, there's a difference between somebody who's taken some continuing education, and then I don't know what that means. Like there might be all different degrees of keeping up with it if it's not really their focus, versus being a lipidologist. So not that I wouldn't take one if it was the only thing I could find, but I would try very hard to find somebody whose title it says under the name lipidologist. So that might mean that like I said, you have to travel, and it might mean you have to fill out all kinds of forms, because I think these people are kind of few and far between and pretty sought after at this point. But oh my God, was it a different story when we started talking to a lipidologist. So I am probably going to do that myself. I have kind of a funky lipid profile. It's a little bit weird. It's kind of high on the good and a little bit high on the bad, but my ApoB is sort of in between, and it's just very hard to know what to do. And for lack of any other information, my doctor and I decided that we were going to have me go do a calcium CT score, which I think is also another easy thing to do. It's usually $100. Most of the time insurance doesn't pay for it and you pay out of pocket, but you might get your insurance to pay something for it. Anyway, it's just basically a CT scan. It's literally 5 minutes, and a calcium score should be 0. Nothing to brag about when you get a 0, because it's to be expected and it's normal. I think a lot of people erroneously go, oh, I have all these problem numbers, but my calcium score is 0, so I'm all clear. That's not totally true. That being said, mine is 0. So the best analogy I've heard about how to think about the calcium score and the LDL cholesterol is that the LDL cholesterol kind of tells you what sort of a neighborhood you live in, and the calcium score is sort of, it tells you whether you've had any break-ins. If there's calcium there, it means that LDL cholesterol has already done some damage in the walls of the arteries of your heart. So for whatever reason, Mine hasn't done any damage that we can see yet. Now, that CT only looks at hard plaque. It doesn't look at maybe soft plaque that hasn't hardened yet, so it is possible I have some of that. There's another test you can do for it, which is more invasive and a lot more expensive, and I won't be doing it. But I am pushing 60 years old, and I have had kind of, like I said, a funky lipid profile for a long time. I suspect that's a family thing. I don't have like heart attacks and things in my family, although there were strokes. And kind of think that I sort of should have had calcium in those arteries by now. So it did give me a little bit of a sigh of relief, not that I'm all clear to just continue, but that I've got a little breathing room right now. And I believe I am going to go talk with a lipidologist, because here's why. Even if you have a 0 calcium score, and if you're walking around with an ApoB that's high, ideally get an ApoB. Ask your doctor to order an ApoB, because it's a much better indicator than LDL. It's sort of, the LDL is kind of a poor man's view of the ApoB, but you can only walk around with a high ApoB for so long, and eventually it will do damage. And my understanding of the ApoB is that it's not even correlative like LDL with the cardiac health. It's causal to events. So I know that I have a little breathing room right now, but I am going to get on this because my ApoB is sort of hovering. It's not real high, it's not nice and low. It's just kind of hovering at the borderline, and this is a very modifiable risk factor in my mind. There's a lot of risk factors that we can't modify, but this is very modifiable, and I want to have a consultation with a lipidologist, because we're getting down to some real nitty-gritty about trying to do a risk assessment of whether and when to treat this in me. And I don't think anybody who doesn't have that background is really equipped to make such a nuanced assessment. So boy, I have learned a whole lot, and like I said, think about this as sort of a public service announcement because I wanted everybody to benefit from all the sweat equity I've put into figuring out what to do with this. So I will link, like I said, the Academy. I think it's called the Academy of Lipidology. I'm not sure. I will link it below down in the description box, and I would encourage anybody who's even thinking about acting on the lipid panel to see if you can't get a consultation with somebody who's got some background in that. So yeah, let me know how else I can help. Oh, I wanted to mention one other thing, which is that I do not want to get into it. Please, if you are like keto carnivore, I have noticed that in some other like discussion groups I'm in, just like the workout I do an X3 system sometimes, and there is a group of enthusiasts, and I go on there just in case I have a question every now and then, but I noticed there are a real overrepresentation of enthusiasts of like a carnivore diet. And you know, unfortunately, I think a lot of things with diet, people, unfortunately, instead of letting the facts take them to the right decision, they decide what they want sort of ideologically, and then they try to pick out facts to support it. I think we all do that a little bit, but there's some real hardcore ideology when it comes to diets. I would guard against that. I think that's a very dangerous idea. But I don't want to get into it with people. Look, if you're doing a keto carnivore diet and everything's working for you, that's great. If you're doing a keto carnivore diet and your lipids have gone crazy, I would recommend that you have a really good risk assessment with a lipidologist, and don't kill yourself over an ideology. That's all I'm going to say. So anyway, with that, let me know what your thoughts are, and I hope this is helpful. And until next time, be well. Bye-bye.